Dr. Lakhani. He's from Ahmedabad. He's very young, energetic, and dynamic uh, endocrine society member, and a lot of works is doing on artificial intelligence. And I request Om to begin his deliberation.
Thank you so much, sir. And thank you for the kind introduction. And thank you to the ESICON organizing committee for having me for this talk. And thank you for making sure that it's not AI. Because, to be very honest, steroid-induced hyperglycemia is my first love, right? My thesis was on this. We have a lot of papers on this. And the only randomized controlled trial on this topic is done by us. So, like I said, this came before AI. And I think really a privilege to talk on one of my favorite topics. So what we're going to do is we're going to discuss practical aspects of managing steroid-induced hyperglycemia. We'll be mainly focusing on in-hospital management, but we'll take a little bit look at the outpatient management also. Okay, so let's take a case scenario. So this is a 60-year-old male patient. He's a smoker, known case of COPD, has been on inhaled glucocorticoids, has been on oral glucocorticoids time and off, right? So you have patients like COPD just coming for steroid short courses often. Now he develops COVID. This is a recent patient, COVID-19 infection, and is admitted to the hospital for the same. Now his vitals are stable. Hence, he was admitted to the isolation ward, not in the ICU, but needs supplementary oxygen therapy. And his random glucose when he was admitted was 180. His eGFR is 50, and he started on, as per the protocol by the pulmonologist, he started on a dexamethasone 6 milligram once a day, right? So this is a very typical scenario. You would have seen patients like this in your practice, and of course, COVID-19, having its ups and downs. You often have patients like this being admitted to the hospital. So patient is admitted under a pulmonologist, and you have been called as an endocrinologist to look at the glycemia. So when you deal with such a scenario, there are a lot of things. So steroid-induced hyperglycemia has a lot of complexities layered, built into it. So first and foremost, you need to see the patient's baseline glycemic control. There will be a lot of patients whose baseline, HbA1c is high. The patient is not going to, already has poor glycemic control. You already had a session on, in-hospital hyperglycemia earlier. And then you're going to give a glucocorticoid, right? So if the patient's, depending on what the baseline situation is, you are adding fuel to fire, right? So the patient's HbA1c was already 11, then you're adding dexamethasone, you're going to only make it worse, right? The other important thing is, and this is again, remember, we are endocrinologists, so you're also bothered about looking at the adrenal, right? Now this patient, for example, the patient like this, he was already given glucocorticoids on and off. So what is the status of his baseline HPA axis, right? Does he have a HPA axis suppression? Are we going to make it worse? Are we going to kind of correct it? So what happens is some patients tend to have some baseline, a little bit of adrenal insufficiency, which gets worsened. So patient may develop hypoglycemia. So that's often an issue. And we'll see how it pans out. We also know that COVID-19 infection itself had impact on glycemia, right? So we also know that. So that also, sometimes, your de novo hyperglycemia developing in these patients. Then, of course, the other problem is a practical problem, right? So the pulmonologist or a lot of the residents will change the dose of steroids depending on the requirement, right? They'll change the steroid itself. So they'll give dexamethasone, then they'll give methylprednisolone, they'll give, discharge, they'll give another steroid. So a lot of things change. It's a very dynamic situation, right? It's, the steroids will be tapered, steroids may be up titrated, so on and so forth. And very importantly, sometimes, combination of all this, the patient already has infection. So infection also leads to a situation called glucotoxicity. In fact, again, when I was a resident, we wanted to do a study. One of the other, studies after we finished the thesis was that, let's look at how infection contributes to hyperglycemia, right? And that is what we wanted to study. Unfortunately, we didn't get fund for that at that time, but that's again an idea which we need to think about. So these are all issues which you will be dealing with when you see a patient. This is, though on paper looks very simple, there are a lot of complexities built into it when you see a patient like this. So what are the things as an endocrinologist you already know, right? What are the things, what are the wisdom that you already know? Now, we all know that the poor glycemic control will impact the patient's recovery from the underlying disease, right? So if the patient has COVID, patient has infection, all that thing will be impacted by that. The glucocorticoids, depending on the glucocorticoid which you're going to give, each of them has a different pattern on the hyperglycemia, right? We'll see some images of that. We'll see some CGMs also for that. You also know that HP axis of such patients may be compromised. And what sometimes happens is that, for example, if you give a morning dose of, Visalon or a prednisolone, what typically happens is patient's HPA axis is compromised, then he has a severe hyperglycemia in the evening, but in the morning time he has hypoglycemia. It's a very typical pattern because the patient is having a compromised HPA axis. So that's often an issue which happens. The infection also, has an impact on the glycemia. You also know that the glucocorticoid dosing change may not be very static, right? The doctor may change it, may not even inform you. The medical officer may not inform you, right? So there might be challenges. So it's always a good idea to anticipate that this could happen. And then you will be blamed for the poor glycemic control. That patient developed hypoglycemia, that in the morning they change the dose of steroid, that they didn't tell you, right? But then patient developed hypoglycemia is your problem, right? So that's often a challenge, right? And of course, different glucocorticoids will have different effect on the glycemic pattern and other things, right? So broadly, if you see current scenario, there are two definitions. Of course, this is very theoretical, does not have a lot of meaning, but you need to understand this again from a sort of a broad framework. So there is something called steroid-induced hyperglycemia, and then there is steroid-induced diabetes. So again, short-term, glucocorticoid use can develop hyperglycemia, but sometimes patient is on glucocorticoid for a long time, or sometimes even, sort of a medium period of time when glucocorticoid is given, it can lead to permanent changes in the system, weight gain and other things, which can lead to permanent diabetes. So it can be steroid-induced diabetes also. We have seen a lot of these. Another area where you do see this being used very often is your transplant patient, right? Post-transplant patients is a common scenario, and a lot of them develop permanent diabetes also after transplant. So this could be issues which could be there. Now, why does steroid produce hyperglycemia? Now, there are, in an acute situation, things are different. In a chronic situation, things are different. So in an acute situation, there is an acute insulin resistance, there is increased hepatic glucose production and reduced insulin secretion. So, and often, especially again, a tip I'll give you, if your patient is on, especially patients who have undergone transplant, tacrolimus also suppresses the insulin production, right? So that's another sort of equation, especially in such scenario, right? On a chronic basis, tacrolimus doesn't have much impact, but on an acute basis, and tacrolimus doses are also changed by the hepatologist or your nephrologist, when they are seeing such patients. Again, on a chronic basis, obviously the patient gains weight, there is sustained insulin resistance which worsens, right? There could be chronic beta cell dysfunction which develops because of steroids, and there is like literally metabolic remodeling, just like your Cushingoid patient, right? So the patient on steroid for a long time, literally is an iatrogenic Cushing which you're developing, and then that also has impact on the patient's glycemia. Now, to tell you our story of this, right? My primary thesis for DNB endocrine was on steroid-induced hyperglycemia, and we actually did a randomized control trial for this. Is the only one from India. The basic idea of this study was we took patients who are hospitalized and we gave a standardized, hospital hyperglycemia management as per the current guideline, and we devised a new protocol, and we compared these two and we saw what is better. What we really found was that the glycemic variability, I'll show you an illustrative case, glycemic variability was much lower with the new protocol which we developed. And then subsequently, there are other publications which we had on this. We had a specific publication on steroid-induced, on post-transplant diabetes also. So this is our, RCT, which was published long time back, right? Many years back, but still relevant. In fact, this was kind of a, very important paper during the COVID time, because, a lot of people actually saw this, and we got a lot of citations during post-COVID period. Suddenly steroid-induced hyperglycemia was in vogue, right? So that was the thing. Now, when we did this publication, this is exactly the problem which we faced, and I got trained in a center which was, sort of a center of excellence for transplants, and steroid was used off and on, right, left, right, and center. Now, when we started this, when I started reading about it, when I started my thesis, this was one of the first papers I read, right? And this beautiful, one image actually captured the entire, my thinking of the entire picture, right? And I think if you remember this, if you just see this image, it's a very old paper by Wang et al. And what he showed something very simple. He said if you give, a prednisolone in the morning time, it produces a glycemic pattern which is something like this. So basically what is happening is that you have post-meal, post-lunch, and pre-dinner hyperglycemia, and then the sugar levels come down. And which insulin matches this pattern perfectly? It's a morning NPH, right? So when you give an NPH in the morning with a prednisolone in the morning, it matches the pattern of a prednisolone perfectly. So his thesis was very simple. When you're giving a once-a-day glucocorticoid prednisolone in the morning, which is of course the most popular glucocorticoid, then you add an NPH along with that, and that solves the problem, right? So this was the thing. Now, when we saw this, my thesis guide told me that, but is it prednisolone is it the only one that we use? Or do we only use prednisolone once a day in a hospitalized setting? So there are more nuances to this, right? Then we realized that a lot of the time pulmonologists often use methylprednisolone twice a day. So it's a very common pattern, right? Now, of course, we could always argue that, whether this is the right way or wrong way. That's not for me to debate, right? That is what the pulmonologist or a rheumatologist is using, and we are just kind of, bearing the brunt of it. So what we saw, and this is the image which I draw from my own hand, I couldn't find anything like this here anywhere else. What we realize is that when you give methylprednisolone twice a day, then you have an addition of these effects. So what happens is, you have the first steroid which is given here, and the second dose which is given somewhere in the evening, and then so you have one peak, there is a sustained hyperglycemia, and then there is a second peak which typically happens, right? So the solution we actually gave for this was, you give NPH in the morning, but to correct the baseline issue, you give a small dose of glargine, right? And a lot of the times, we often get saying that this doctor doesn't know anything because, he's giving two types of different basal insulins. But the idea is this. So you cover the morning prednisolone with the NPH, and you give to cover the base and the glucotoxicity, you give a glargine. So this was the idea of when you have it twice a week. A good way of also is doing twice a day NPH also. So that's perfectly fine. But NPH has its own issue in terms of nocturnal hypoglycemia and other things. So glargine is something which we are kind of more comfortable on a long run basis. Then the other very popular glucocorticoid which is used, especially, and you would have seen a lot of oncology patients, right? A lot of your patients who undergo breast cancer surgery and all that, they are on chemotherapy. And whenever they are admitted for chemotherapy as a treatment, they are given dexamethasone. Very, very common pattern that we see. So patient's glycemia is otherwise fine, but the patient is given dexamethasone and suddenly the patient's blood sugars go up to 200, right? So again, there's a paper by Zhang who actually who did a CGM of patients who were, like this on chemotherapy, who were given IV dexamethasone. And what he found was that there are a couple of peaks. So there's one peak, right? So initially, at about 72 hours, patients develop a peak, and then they develop a second small peak at about 120 hours. And then there is then it plateaus out, right? So it remains slightly higher than the base, right? So this is what typically happens and then about 5 to 7 days later, the things go back to baseline. And by that time, the patient has the next cycle of chemotherapy, right? So this kind of cycle becomes a permanent issue. So there's one peak which often happens immediately when the glucocorticoid is given, and this we have to anticipate. We actually did, this is Zhang's study, right? He actually showed one case scenario, right, where he did some CGMs also and found this typical pattern. So he says this pattern is very typical, that you start with, there is one peak, then there's a second peak, and there is a plateauing, right? So that typically happens after a single dose of dexamethasone. So we also, took some CGMs of our own patients, and we found a similar pattern. So you see this patient, right, the CGM data, patient is actually non-diabetic, right? And you're giving dexamethasone over here. So you're seeing that first peak happen here. And then, it kind of plateaus. And then, by the time there are certain, trailing sort of second peaks also, which kind of go on, right? So this is a very typical situation that we see. Now, all these things were great ideas, right? Great concepts, but none of them was battle tested, right? None of them was actually, there was no, evidence to prove that. So that's where we came up with an evidence for that, right? So what we did, we actually came up with a very simple solution. The solution looks very intuitive but simple, but at the same time very effective. So first, there are two things. One, you match the insulin which you're going to give with the steroid which you're going to give, and the pattern of glycemia should match with that. So if you're giving prednisolone, you go with what Wang had originally said. Along with the prednisolone, you give an NP, right? If you're going to give short-acting steroid, right, like a hydrocortisone, then you give a short-acting insulin along with that. That is a regular human insulin. And the third is, if you're going to give a dexamethasone, which you saw as a more prolonged action, then you give a longer-acting insulin. Now, at that time, degludec was just coming in the market. We were still, but we had glargine, so we gave glargine. But in current scenario, I would rather say a degludec is a great choice for this situation. So if we are giving dexamethasone, it's a good idea to give degludec along with that, right? That matches the thing. The second innovation which we did in this paper was that along with the steroid, right? Remember the pulmonologist or whatever, doctor who is controlling the glucocorticoid is going to change the dose of that. So once you achieve that, correct NPH dose, then depending on the dose of the prednisolone which they are changing, you change the NPH dose, right? Don't change anything else in the equation, which makes it very simple. So my patient is on, insulin, on a glargine and maybe short-acting insulin, and I'm giving NPH in the morning with a 30 milligram of prednisolone. And after 1 week, the patient has been told to reduce the dose to 25 milligram. I proportionately just change the dose of the morning NPH, and I don't change anything else, right? So it becomes very easy for the patient also to understand that, when the dose of steroid is changed, you change the dose of the insulin that matches the steroid, right? And my, diabetes educator, she always explains that this insulin is for the steroid, right? So when steroid doses change, this insulin changes, right? And the patient clearly understands. And when the steroid is discontinued, the insulin is discontinued, right? So that's an easy, intuitive way of working with it. So this is the thing. So we have this entire paper is available for free download. I'm not going to go into the details of that, but the idea is that this is how you basically, structure it out and take it out. So there could be non-diabetic patients who will develop hyperglycemia, where you just give a single dose of NPH with a prednisolone, it works. And there could be patients with more complicated, poorly controlled diabetes, where you look at it in a more nuanced manner. All right. So again, we matched all this and we came up with this solution. And what we found was that when you compare all these things, the glycemic variability, even though the glycemic control was very similar in both the groups, the glycemic variability which our patients had was much lower because of the fact that, so remember, variability also means hyper and hypoglycemia. And we had much lower hypoglycemia in our group compared to the patients who were given standard of care, which was basically standard basal-bolus therapy. Right? So this is the thing. Now, we actually published another illustrative case in the, the International Journal for Diabetes in Developing Countries, where we gave a case report to show the example. Now, this is the patient who basically was given a prednisolone. She had some rheumatological condition. She was given prednisolone. This is before. So this was our patient on standard basal-bolus therapy. And the same patient, what we did was, we removed the standard basal-bolus. We just gave the patient an NPH, and you can see the difference, right? So very simple. Instead of 4 shots of insulin with a lot of glycemic variability, we gave 1 shot of insulin, which matched the prednisolone, right? And the patient's glycemic control was much better, right? Now, there's a lot of argument in this paper that, initially when this, so we came into the picture after 5 or 6 days when the ICU people could not manage the glycemia, and they said, we want an endocrinologist, right? So the argument from the ICU people was that when we had already broken the glucotoxicity, you had it easy, which is probably true. But having said that, the point is that, sometimes maybe not having too much insulin, probably smart way of using insulin is better, right? So that's the whole pattern. Okay. Again, we are proud to say that our paper actually got acknowledged in the Endocrine Society guideline on this particular topic, right? In fact, this original idea, like I said, we are the first to do worldwide, the first RCT on this. There are many papers after this which came, which actually took the same idea, right, and took it forward. But subsequently, and I would say we did modify our approach to some extent. We also learned from the other papers which were published later on. And what we found was that you saw with dexamethasone, there is that initial peak, right? So what we realized is that even if you give dexamethasone or give methylprednisolone or you give prednisolone, or even in some cases, even hydrocortisone, the patient does have an evening peak initially, which is very similar. So what, again, as a standard of practice, what we have started doing now is that when we discharge the patient, we batch it with the steroid, right? If the patient is going to be discharged on a dexamethasone, then we batch it with the steroid. But when the patient is initially admitted, right, and the steroid is introduced for the first time, at that point of time, we give NPH along with the baseline basal-bolus therapy. So you give the basal-bolus therapy, plus you give an NPH in the morning time, and that works even for dexamethasone or hydrocortisone or other forms of steroid also. This has actually been done in several papers who were published after this, and they actually, cited a paper saying that, probably NPH alone works better. You don't need to match with the steroid, but we are probably right from a discharge perspective, but initial admission perspective, probably this approach also works equally good, and this is what we learned, especially during the time of COVID. Okay. Right. So, yeah, so this way we modified the approach, and our current approach is in a hospitalized patient is very simple. We give an evening basal insulin, right? We give a morning NPH, and the short-acting insulin is basically, so again, keep things simple, right? So this is a much more simplified approach, and we give short-acting insulin as per the, requirement, as per the hospital hyperglycemia management guideline. So this is the, this is the protocol which we have. And during COVID, of course, there were other challenges which we faced, right? So during COVID-19 pandemic, again, there were insulin shortages, there were NPH. NPH is a big problem, right? When I'm saying this, while I'm saying this, currently the flex pens for NPH are being discontinued by the company, right? So NPH availability alone is going to be a challenge in the future. There are protocols where we develop where we are using premix. Unfortunately, premix is much more easy to avail than NPH. So you could use a similar approach with a premix, right? But the problem is that sometimes you have to be very careful, because when you're having the short-acting component with a premix, the patient already may have hypoglycemia in the morning, and that could lead to a problem, right? So then patient develops worsening of hypoglycemia, which could be a challenge, right? So this is the thing. Now, I'm not going to discuss about the specific COVID-19 management. I'll just give you 2 sort of, outlines which you can follow for your patient, right? step-by-step approach. So whenever you have a patient, and this kind of summarizes our current approach of glycemic management in 2 slides. So whenever you have a patient with who is first admitted, right? If the patient has severe glucotoxicity, so the random sugars are 300, 400, it is always imperative that you start the patient on IV insulin, right? Because that is the only thing which is going to break the glucotoxicity. So that's the first thing. Very importantly, as an endocrinologist, you should also be mindful of the fact that the patient would have some sort of an HP axis involvement, right? Patient could have a compromised HP axis, so you have to be careful. And remember, that is also your role, right? Your role is not just glycemic management, your role is also to manage the HP axis. Whenever the patient has a fasting blood sugar more than 140, you start a basal insulin in the evening time and start an NPH in the morning time, depending on the equivalent dose of the prednisolone, right? So if the patient is on dexamethasone, you convert it to the equivalent dose of prednisolone and give an NPH in the morning. So that's the approach. Then short-acting insulin you give as per the protocol. And the most important thing, how do you titrate the dose of insulins? So the morning the fasting blood sugar, you check that and you titrate the evening basal insulin based on that. And the NPH which you're going to give in the morning, right, you titrate based on the pre-dinner sugars which you're going to get. So that is how we kind of balance it out. Also, remember, you have to take into the equation that the patient's steroid dose will also be changed. So if the steroid dose is changed, you just change the NPH dose which you're having in the morning, right? Which makes it very simple and intuitive. So that's the whole approach we have as far as hospital hyperglycemia management is concerned. I think if this 6 steps literally covers most case scenarios that you're going to encounter. Of course, there could be special circumstances, but most cases this is being covered. What about outpatient management? Now, I'm not discussing too much detail, but a similar approach can be used in outpatient. But remember, in outpatient scenarios, there'll be situations where you may not use insulin, you may just use an OAD. Now, you could simulate a similar protocol with an oral antidiabetic drugs. So again, you have to be mindful of what glucocorticoid is being used at the time of discharge. Remember, what is given at the time of admission may not be given at the time of discharge, right? Patient may be on dexamethasone at admission and maybe on methylprednisolone at discharge, right? So be careful of that, right? Again, wherever possible, it's a good idea for your learning also to use CGM in such cases, because at short duration period, steroids will be given for 15-20 days. You can use CGM. It also helps you and your patient, right? So these patients, also learn the process. The NPH plus insulin regime works in this scenario also, but like I said, patient may not be ready for insulin, or, all situations may not need insulin. But again, an insulin-based approach, similar approach does work. Short-acting insulin may be given, right? Also remember, be mindful, and this is what we learned from our own CGMs of patients who are discharged. When you give the bedtime glucose value has a very strong impact on the morning glucose value, right? So if the patient's bedtime glucose is a little bit lower, patient is likely to develop morning hypoglycemia. So be careful of that scenario. So all that thing. And finally, reduce the dose of your insulin depending on the glucocorticoid dose, which is going to be changed. And remember, the steroid, sort of down titration protocol will be explained by the pulmonologist or rheumatologist. You also need to be aware of that, right? And you also need to kind of counter that, right? As far as, OADs are concerned, or maybe if you have an OAD approach, you could use, I'll just finish that last slide. You could use a similar approach. You could have a synthetic approach. Just be careful of SUs. And my recommendation to you is not to use long-acting sulfonylureas, which can produce hypoglycemia when the doses of steroids are changed. The newer agents, DPP-4, SGLT2, if the patient has no contraindication, and GLP-1RA are excellent choices of drugs for such cases, right? Alpha-glucosidase inhibitor, I don't know, I'm a big fan of that somehow, right? Also is very useful. But remember, what we typically have learned is use 110 or 120 type of phenomena, right? Give it in the morning, give it in the afternoon, don't give it in the evening, right? And that kind of works perfectly for us. And then again, wherever insulin is required, you can consider using it. Thank you.
Thank you, Dr. Lakhani. He has presented very well. He told us about the type of insulin should be matched with the type of steroids. And he has given a very simple algorithm. Otherwise, usually every one of us faces a lot of problems while dealing with steroid-induced hyperglycemia. So thank you, Dr. Lakhani, for the excellent presentation.